Welcome to Mental Millennials with your host, Shelby Friesen.
So today I'm here with Dr. Richardson, and he has been my family doctor for as long as I can remember. And we actually recently had sort of like a reconnection. I hadn't seen him for a while, a few years, and then I started doing some triathlon training, and it was a weird coincidence that the lady I was training under, she actually knew Dave, which that Dave is his first name, which is weird for me to say. But she reconnected us, and I'd reached out through email, and then we actually went for a bike ride, I don't know, a month or so ago, and kind of reconnected and talked about like what had happened through my life recently with like mental health and other things. And then decided that we were going to do this podcast and kind of chat about what, like becoming a doctor, some of the stuff around mental health in my situation with Dave, and kind of our contact with my kind of first seeings with anxiety and things like that. And then we'll just see where it goes from there. So I'll let you introduce yourself quickly, and then we can kind of get into your story a bit.
Excellent. Shelby, thanks for having me. I just want to start with apologizing for dropping you on your head when you were a baby. It explains a lot to all of us that know you, but I do feel responsible for that. So yeah, I don't know what you want me to say introduction wise, but yeah, I'm a family doctor. Been doing it for 30 years or so. Had the privilege of being yours. I don't know if you want a little bit my background or.
I think that yeah, sure. Or we can just dive right in. Like, yeah, sure. Give some background, and then we can just kind of dive into how you became a doctor and why, and then go from there.
Yeah, sure. My bio is I'm a local boy. I grew up in Tsawwassen. That's my hometown. And I went to SFU, then UBC medical school. I interned at Royal Columbian in New West, and did some locums and filled in for other doctors in Richmond for a number of years, and came out to Langley, I think 1991. So that'll be 30 years next year. Yeah.
What's a locum? Sorry.
Oh, sorry. Locum tenens is like it's like a Latin name for a doc who fills in.
Okay.
So for example, when I go on vacation, if I'm lucky enough, I can find a locum to work for me while I'm away.
Okay.
Yeah.
So you went you kind of went all around Vancouver with the practices.
Yeah. So a lot of young docs, when they come out of medical school, they don't want to necessarily set up their own practice right away. So they'll do what we call locums. So, for a couple of years, they'll fill in for different docs, kind of figure out what works for them, what they want to do.
Okay.
So, yeah.
Sweet. Okay. Well, let's just dive into where it kind of started for you. Like when did you decide you were going to become a doctor?
Yeah.
Or how did that come about?
That's a good question. In school, I was always interested in sciences, and, my brothers both became engineers, but that didn't really interest me. I wanted more of a sort of a people contact.
Mm-hmm.
So if you combine sciences and interested in people, then medicine seemed like a natural choice.
Mm-hmm.
So that just kind of fell that way.
Yeah. And did you get into it like right after high school?
Well, you have to do what we call pre-med, which is you have to do, when I was around, you had to do a minimum of 3 years of a number of courses before you could apply to medical school.
Mm-hmm.
And after I made a large cash donation to the medical school, they accepted me after 3 years. So some people get degrees, like some people get a Bachelor of Science degree or a Bachelor of Arts degree or even a master's before they apply. And then medical school is 4 years, and then 2 more years of residency when you're done.
And what's residency?
Residency, you're a doctor, but you're not. You have to sort of jump through some more hoops, kind of like articling for law students before you can, they say, come to the bar, but I don't know, come to the stethoscope, I guess is the equivalent. So.
And when you first, I guess like in school, when you're in school, like, do you work with patients and like people, or is it mainly just like textbook stuff? Like, I don't know anything about what you actually do.
Sure. Medical school, it's been a long time since I've been there, Shelby. But in general, you start with more classroom-based learning. Mm-hmm. So you do anatomy, physiology, biology, those kind of things, and then you would move into more clinical work. Mm-hmm. So usually the first couple years are more sort of classroom learning, and then they unleash you in the unsuspecting public, usually in your third year.
Okay, and then you get to work on actual people.
Yeah, it's all supervised. So, you would have a clinical instructor who would, you'd see people and learn how to examine people and, come up with diagnostic plans and, sort of an investigation process. And yeah, so that's kind of, and then the progression goes like by the time you're in your last year of medical school, you're doing more and more. And then when you're a resident, you're essentially doing everything, but you still have a supervisor. It is an adjustment when you finish being a resident and then you're working on your own and it's all of a sudden, oh, wait, there's nobody else supervising me anymore.
You just do whatever you want.
Like, oh, wait, there's no control on me anymore. So, yeah.
When that happened too, like, do you feel like, I feel like there's so many things to pick from when you're like diagnosing people and stuff. Are you ever like, you must be second guessing certain things that,
yeah.
or like when you first started, like,
yeah, I think that's probably probably one of the issues when you first start. It's like, oh, well, I think this is a cold, but then your head starts going, whoa, what if it's, polycythemia rubra vera and it's really rare, but, so I think you get more comfortable with, the sort of common diseases and not overthink things and have it settled, have it settle a little bit more down so that you can just kind of do your work. Yeah. But you're right. I mean, if you can certainly get stuck thinking of the infinite possibilities.
Yeah, there's a lot of them.
But that's what you can always look things up. You can always ask somebody else. You can do some investigations that might point you one direction or the other direction. So,
and then through like my practice, like through me seeing you, like there's been so many different things. Like I've came for like colds, and then I've came for like surgeries, and you've like cut my arm open and taken stuff off my arm. Did you learn all of that in medical school, or do you like go and learn different surgery things after?
Yeah. So in medical school, you have an exposure to a lot of things. And then what I did back then was what's called a rotating internship. So when you're done medical school, it's a year of where you work at a hospital essentially as a slave. And you sort of do a rotation in surgery, you do a rotation in obstetrics gynecology, you do a rotation in pediatrics. That's where you develop a lot of your skills. But I mean, learning, as you know, is an ongoing process. It never stops. So
you're always learning.
I'm pretty sure I'm not going to do brain surgery in the office, though.
Yeah,
pretty sure. There has to be some limit. Right? So,
yeah. That's cool. Yeah, I think that's cool how you get to try all the different things. Kind of reminds me of like grade 8 when you go through all the different like cooking and woodwork and stuff. You get to kind of taste every aspect of it and learn about everything.
Yeah, and then some people, they go through their medical school journey and they decide early on, I want to be a neurosurgeon, and so their focus becomes really quite narrow. So.
Yeah, so you've basically stayed broad. You haven't narrowed into anything.
Yeah, mostly because I don't have the intellectual ability to really be good at anything. So I'm pretty average at a lot of things. So.
That's good though. I like that. I like being 80% at a bunch of stuff instead of 100 at one.
Exactly.
I guess like we could, I don't know, do you want to jump to kind of my scenario?
Sure. I think that would be, I think that would be a sort of a great way to jump into your scenario. Cause I really respect what you've done and how you're trying to help people and, your mental millennial sort of platform. I think it's definitely needed. So,
okay.
Yeah.
So with me, like 4 years ago in my story, when I first realized like something was really wrong, it was that night after drinking. I was feeling really weird. And normally the things would just go like away from me. And I felt like if I just wait one more day, and that day never really came until I realized I should probably go see someone, go to the doctor. And when, like, I guess for me I always had the belief that like, didn't matter what I did. I could just go see a doctor and I'll be okay. I'd be like, you know what? It doesn't matter. I'll eat shit. I'll do whatever I want. And then I'll just go to the doctor's office and they'll fix me with whatever they do because they do that. And then I'll be fine. And the only thing I'd ever really thought about getting was like diabetes, because my whole family was like, you just eat so much sugar, all this stuff, you're going to get diabetes or you're going to be fat. So my kind of like view on health for my entire life was whether I was thin or had diabetes, which like, I don't know how I would ever tell if I had diabetes. I wouldn't know until I got tested. But since I was always thin, I just figured it was okay. So when I came to
just your test did come back. You have diabetes. Sorry to bring that up now. We'll talk later.
Yeah. So when I first came in to see, and when I came to see you, I don't know if it was you or there's another doctor in the office, and it was always one or the other. I forget his name, but I don't remember what I said. I just knew that like I was I didn't even know what was going on. I didn't know that I was having extreme panic or anxiety. No one ever talked to me about it before. I'd never heard it from a friend saying like, this is what you're experiencing. No one really talked about it that much. So I had no clue. So when I came in, I remember, well, I would know that I would have explained some sort of thing to you. And what I remember is being prescribed for Ativan to calm down, and then being told to get some exercise. And for me, I was just like, I was too scared to take the drugs because I thought, I don't know, I was just having my own issues about taking pills and stuff, so I didn't want to do it. And for some reason, for me, I didn't believe that they would be a fix, I think. I just thought like, man, I don't know, like I'm so messed up. I don't think that's going to help. And then for me at that point too, like I could barely move at home. I was like, man, like there's no way I can go for a run or exercise. So I wasn't sure what to do. But I think like looking back on it now, I wonder, like my thing about it is like the communication of like, I don't even know what's going on then. You know what I mean? So like, I guess I wonder how you felt, or if there's anything that you remember from it. It's probably not a significant memory for you, but wondering how, like for me, it's like, how can the communication be better between the two people to explain those situations, or what kind of other scenarios or experiences have you had with mental health that are maybe similar or different, or do you have that?
Yes. Yeah. I mean, we talked about that a little bit on our bike ride, how, in many ways I feel like I failed you. I mean, you were struggling, and, I mean, I don't remember the exact visits, right? But, I think you were trying to articulate your struggles and perhaps didn't have the language to do that. But, it's my job to also pull that out of you and maybe help you with that language, So, but it's also a difficult process in an office visit, a young man comes in, he says, I have these physical symptoms, and, probably the conversation went something like, well, I probably would have taken your history and examined you and said, Shelby, like things seem okay. We should maybe do some tests just to make sure that, your blood and everything's okay, that you don't have diabetes.
Yeah.
And I might've talked about, do you think this could be anxiety? And maybe said, this is something you can use for overwhelming anxiety while we try to sort this out. But I don't know. I think part of the solution is to bring mental illness out of the shadows and to encourage a discussion. So, your part by having the conversations that people will hear, the next young guy comes out and says, hey, this mental millennial guy, I've been listening to him, and hey, I think I have anxiety. So I mean, and that's a start to be able to go see, your physician and say, like, do you think it could be anxiety? What can I do here? Like, I'm really suffering. And I don't think men in general are very good at articulating their suffering. Like we tend to keep it inside. You say your symptoms, and then, what did he say? Oh, he said, I'm okay. And I think we just go, okay, fine. Kind of like suck it up.
Yeah.
So, I don't know what kind of advice could have I given the younger Shelby? Yeah, I'm not sure. It's hard to go back, but, like certainly if I see Shelby too, tomorrow tomorrow in the office, that maybe, my antenna are going to be a little bit higher. But yeah, I think I would tell patients, just to be persistent, and maybe say, okay, that's all very well, but what else could I do? Like, I just don't feel good. You're like, are there other options here? Is there somebody else I should see? Is there things I should do with my life? And I think if you have a good relationship with your doctor, you should be able to have those conversations. But again, like 20-something-year-old males are not the biggest conversationalists.
No.
Right?
Yeah.
Like, how are you? Fine. So.
Yeah. And I think a lot of it for me too was like feeling like I was crazy, where I'm like coming in like, man, like I'm having a heart attack. Like I swear I'm going to die. And I don't know if I expressed those things, because I felt like a lot of times I'm like, okay, like I'm 20, like obviously I'm not going to die, but like it feels like that. And I think that was the biggest thing for me too, where it's like I'm trying to explain that I think I'm dying, but then it's like, okay, man, you just need to calm down. Like you're okay. It's fine. You just need to like figure that out. And we definitely did do all the stuff you talked about. Like I did a diabetes test through you, which did come back negative, but we definitely did lots of testing and all that stuff. And that was, yeah, it's like, I think the hardest part was for me to actually explain what the hell was going on, and have someone on the other end be able to tell. And like, I think another thing I wonder is there a place where, like, is there an area, like where do you tap out with help with mental health? Like where, like, because there's obviously certain things you can do. Like, and true, I did actually learn that the first time I thought I had anxiety was from coming in to see you. So like, if I didn't do that, I wouldn't have known what it was. So that was something, but I still didn't really, okay, like I had anxiety, but I didn't understand what that meant. So trying to like figure that out, and then wondering like where, like, I don't know, do you think there's an area you tap out where you would pass it off to somebody else?
Just by the sheer volume of patients that I have, I can't spend 2 hours with you to talk about anxiety.
Yeah, I know.
Like,
yeah.
I can't do that. So, so I'm tapping out at that point.
Yeah. Like if it becomes a talking session or something, you would send it to someone else.
In general, with mental health, there's 3 areas that are really important.
Okay.
So, and no area is more important than the other. The first is lifestyle. So, and I think, you discovered that pretty much, on your own. I don't know if we had conversations about it.
We did.
I guess I said exercise, but
yeah, you said exercise. I mean, we definitely talked about like, okay, like you're definitely like eating pretty, it's just hard to say too. I mean, I guess the word healthy is like, everyone's version of healthy is different.
It's true.
So that's a tough way to go with it, but yeah.
A bottle of vodka a day is pretty healthy. Yeah. So, I mean, I try to talk to people about lifestyle, good nutrition, staying away from alcohol and drugs, particularly if you're suffering, mood wise, good sleep habits, do things that you enjoy doing, in that whole lifestyle thing, probably all relaxation techniques, mind body work. Some people find human touch, really useful. So that's sort of the one area. And then the second area is counseling. I almost always suggest to people, it's a reasonable idea to try to find a therapist. It's a real problem because it costs money.
Yeah.
And there's not a lot of good therapists around who are going to see you for reduced rates. Not everybody has, an extended health plan that will pay for it. And then the third area, and like I think almost everybody has issues in their life that contribute to their mood disorder.
Oh yeah.
And I mean, mood disorders are very much genetic, but also very much environmental, and often a mixture of both. So sometimes you'll see people who, by everybody's estimate, they have the perfect life, perfect family, everything's going well in their lives, but they suffer from anxiety and depression. But if you look at their family members, their siblings, their parents, grandparents, all suffered from a mood disorder. And on the other end is, people who don't really have that history, but someone like their child dies and they become depressed or anxious. But I think most people are somewhere in that spectrum. So, I mean, I think they probably have the genetic predisposition, but then they also, something in their life is contributing to how they're doing.
Mm-hmm.
So that's what, counseling I think is really, really useful.
Mm-hmm.
And then the third area is medication.
Mm-hmm.
And medication shouldn't just be thrown at you; it should be combined with those other things. I remember a study where they took people with anxiety and they exercised one group, another group they gave medication to, and then the third group they did both.
Mm-hmm.
And the group that exercised did just as well as the group that took medication.
Mm.
And the group that took both or did both actually did a little bit better.
Mm-hmm.
So, and the medication choices range from carrying around something like Ativan, which is essentially a tranquilizer. That surprisingly, though, for a lot of people with anxiety and panic attacks, they carry around the Ativan and they don't need to use it.
That is something that we talked about.
Because it gives you control back. So when you start freaking out and you're just getting like, I'm going to die, or, you think, oh, I can take one of these pills and it'll calm me down. And then by thinking about the fact that you can take one of these pills, you don't have to take it.
Mm-hmm.
So, I have a lot of people who suffer from anxiety who carry around, 5 Ativan pills. And a year or two later, they come see me for another 5 because the 5 have disintegrated in the bottle. But it's like a safety measure that they have.
Mm-hmm.
And then, then there's medication you take every day to try to improve your anxiety or your depression.
Mm-hmm.
And, one of the biggest struggles in primary care or being a family doctor is the lack of mental health resources.
Mm-hmm.
So to try to access a psychiatrist. So you've done all those things and somebody's still struggling. And you're doing your very best. It's really difficult to access more resources because they're so limited. And the truth is there's a significant population of really mentally ill people, schizophrenia, bipolar disorder with, some psychotic symptoms, and the psychiatrists are busy often, and the mental health centers are busy often, dealing with those individuals.
Mm-hmm.
So it's a challenge, definitely is. So where would I tap out? I'd probably like to tap out earlier.
Yeah.
A lot of the time, not in your situation, but sadly, sometimes I'm the only game in town for my patients. So I do what I can.
Yeah.
One thing in our office now is one of our staff she took the psych nurse course, so she's a psych LPN.
Yeah.
She's a really good resource because she'll spend time with people and talk to them. And
oh, that's awesome.
yeah, that's a relatively new development.
Mm-hmm. Mm-hmm.
Shout out to Kelly.
Yeah, that's awesome.
So if Kelly was working was in the office at that time, that would have really helped you and I, in that I could say, hey, Shelby, maybe come back and spend an hour and talk to her, and maybe we can get to the bottom of this a little bit. So
yeah, because maybe she can even like dig in with some of her stuff, and then
she just has more time.
Yeah, right. Yeah, I think it's tough with and with your scheduling and stuff, when you bring people in. Do you choose the length, or how is the length set for each client?
I'm basically in charge of the booking process.
Okay.
But there is physicians, the majority of us in BC, not all, but the majority of us work what's called fee for service. So ICU, I send a bill to the government for an office visit to see this patient.
Yeah.
And to make an income, you have to see, a number of people, but you also want to give it adequate time. So it's a balancing act.
Yeah.
And since there's not enough family doctors, there's always the pressure. Will you take my brother? Will you see my cousin? My friends moved to town. So there's so many people who don't have a family doctor.
Mm-hmm.
So, I'm pretty good at saying no, but I mean, if you said to me, you're my best friend, I would probably say yes.
Yeah.
And so, the sheer volume, it's kind of like having a busy family practice is kind of like, this beast that needs to be fed.
Mm-hmm.
So you can't really just sort of sit around and put your feet up and, that's not what it tries. But you can't sort of maybe go at the pace that you would like to.
Mm-hmm.
It's always kind of a pace maybe a little faster than you would like it to be. And that's a problem because I think, when you're moving faster, often, little things that you could do that could make a difference don't happen.
Mm-hmm. Yeah, I think that's and I think that's the other part that a lot of people don't understand is that it also to be a business and the way it works, even with the government and everything else, like it has to make money and work. Like if it doesn't help anybody at all. It wouldn't be there.
Sure.
So I think being able to see that, like, obviously there's a point where,
and everybody wants you to be on time, but
Yeah.
they want you to take lots of time with them.
yeah, yeah, right.
Nobody wants to wait,
No.
but they want to. They want to make sure you take your time when you're with them.
Yeah. Well, and so how many patients like are like you like because your practice is like full right now?
Yes.
What's the like patient number that you guys have?
Well, it's a good question, and the reason it's difficult to answer, there's a few thousand, I would think.
Okay.
But you know, because some people might see once every 10 years,
Right. Right.
and then there's other people I see every week.
Mm-hmm.
So and that adds up close. In general, you know, men between the ages of like 20 and 50,
Mm-hmm.
I hardly ever see them.
No.
I usually see them when they hurt themselves,
Okay.
right? You know,
Yeah.
But typically, so, and then there's other groups, like if you have an 80-year-old with diabetes and heart failure,
Mm-hmm.
you know, COPD, and, you know, you're going to see that person much more frequently.
Mm-hmm. Oh, that's kind of crazy. You don't really see men at all in that age range.
Well, no, yeah, I mean, and that's another thing that I think we can do better as men.
Mm-hmm.
You know, I think women are much better at sort of saying, well, I have a problem. They talk to their friends about their problem, and their friends say, hey, why don't you
Do something.
go do that? You know?
Yeah.
I just remember there was this comic where, you know, the guy comes home and he says to his wife, yeah, well, Bob broke down in the lunchroom today. And she goes, well, why? What was going on? We laughed. We thought he wanted to be alone, you know.
Yeah. Yeah.
Where if it was a bunch of women,
Yeah.
you
Yeah.
know, they would be like, what's wrong? You know.
Mm-hmm.
So I think we can do a better job as men to talk to each other and encourage each other to get help.
Mm-hmm.
Which, by the way, it's Movember.
Yeah.
So this is my
I was
mustache.
gonna say, you know.
I'm 4 days. This is all I got.
Are you actually?
Yeah. You can't even see it, right?
No.
I think you didn't shave this morning, and
Yeah.
you've got more than I did.
I have a couple days too. I think on November. I'm
Yeah.
from the first.
And Movember, you know, like they're focusing even more now on not only like men's cancers like prostate cancer and testicular cancer, but the real focus this year on mental health.
Mm-hmm. Yeah, I've been seeing a lot of posts about it.
And I think that's great. And I think mental health is really it's really been a struggle for a lot of people since COVID hit.
Mm-hmm.
A lot of people who were vulnerable emotionally in the first place are now very isolated.
Mm-hmm.
And we definitely have seen a lot more mood disorders, or people who have a mood disorder but were functioning pretty well.
It's worse now.
It's worse now.
Yeah, I honestly keep forgetting that COVID's a thing sometimes because like it hasn't really affected my life that much in like my day-to-day things. But yeah, like people who are going out and doing all these things are used to being around people all the time. And depends where you live too, right? Like for me, at least I'm kind of out here. Like I can go for a walk in nature and stuff. But if you live downtown or in Surrey or somewhere in like a high rise, you're kind of limited to a very small, darker space.
And a lot of seniors too. A lot of seniors, you know,
think about that.
really rely on, you know, family visits. And you look at a lot of the people in the care homes. I mean, they don't get any visitors.
Mm-hmm.
You know, some of them have mild dementia, and now they can't even get a visitor. They don't understand.
Mm-hmm.
You know, someone with dementia to explain COVID to them, well, you can explain it again tomorrow. But
Yeah.
you know, like it's been a real struggle for I think a lot of people.
Mm-hmm.
So
Yeah. And like in the old folks' homes and stuff, like do you see patients that are in them?
Currently, they're pretty shut because
Yeah.
we try not to have people going there. But I have patients at various old folks' homes.
Mm-hmm.
In general, they come to me.
Oh, okay. They bring them there.
I do go visit them. What's sort of happened over the last 10, 15 years or so is that a lot of the homes have a designated physician that works there.
Oh, okay.
And they actually go there like once a week, so it's probably better for everybody.
Mm-hmm.
Because, you know, if I'm trying to see them, I'm going there, you know, either on my way to the office or when the office is done.
Mm-hmm. And during COVID and stuff too, were you doing any telehealth stuff?
Yeah. So one of the biggest changes was when COVID hit, people stopped coming in. Like they just stopped coming in. They stopped coming to emergency. They stopped coming to my office. It was
because you work in the hospital too.
So it was kind of eerie. Like it was like, where are all these people? because normally it's crazy busy and they just stopped. And I was getting home early. I was taking nice long lunches. And then a good thing in collaboration with the government and the doctors of BC, they came up. We could always make telephone calls, but they actually made the telephone call essentially equivalent to an office visit. So then, we could call people instead of seeing them. They didn't have to come to the office. And that worked really well. So the number of phone calls rapidly grew as people figured it out. It wasn't necessarily a good thing for some because, usually somebody phone my office, it takes a couple weeks to get in to see me unless it's an emergency. But some people figured out they could phone me every day. So
that was my second question. Like, how many people started calling a lot?
Well, there's always a few. 99% of people understand and are, basically decent and get it. And that the 1% who are perhaps the worried well are really anxious. Well, that's who they are, right? So anyway, so the number of phone calls probably we were, seeing probably was like 80-90% phone calls, maybe 10-20% people in the office. We never closed. Yeah. There's certain things you can't do over the phone. I have a spear through my head. Well, grab the pointy end and, so we were always still seeing stuff. And then as COVID sort of, got through the first wave, it got about 50-50. Okay. And now as we're moving into the second wave, so far we haven't seen a huge increase in ill people with COVID. So the numbers are higher. So we keep setting records for daily cases, but the hospitalizations and ICU admissions they've jumped a little, but they haven't jumped as much. I don't think they're at the levels that they were when we were really, high, like April, May. And that's really the measure of the disease. Back in the spring, we were testing everybody. We were only testing, healthcare workers, if you were sick enough that you might have to be in hospital. And now everybody's getting tested. So, the next few months we'll see what happens, whether those, the number of hospitalizations and the number of ICU admissions starts climbing, then, the actual burden of disease is going up. So,
yeah, because if it's not really it's not killing people.
Well, I think two things. We're doing way more testing. So I think initially we thought probably the death rate was around, somewhere between 6-7%. And it seems like it's more around 2.5-3% of people who are getting infected. So now we're picking up way more cases, so we're getting probably a better measure of how lethal the virus is. And also I think the demographics have changed. The people who are coming back positive are all a lot of young people in that less vulnerable group. The 20 to, let's say 18 to 20-year-old, so maybe 30-year-old partiers are making up a big proportion of the people who are, testing positive. The problem with that, of course, is if you have a reservoir of positive cases in your community, eventually it's going to trickle into vulnerable people. Right. I mean, that's the real risk. That's the real worry.
Yeah, it seems like, I don't know, it's kind of funny from my end where I think that's what I liked about this whole scenario, as bad as it is that things like bars and stuff closed down, clubs, and you can't stay out late. I just don't enjoy doing that, really. I'm happy to go for dinner with people, but I was a big drinker at one point in my life, but lately, so now for me it was almost hey, I never have to get asked to go out to drink ever, as long as this is here. But what I see...
Just be clear, you're not suggesting the pandemic continue, so you don't have to get asked to go out.
Yes.
Oh, you are? Okay.
Yes.
It's okay. You heard it here first.
Yeah. So, but for me, it's crazy to see how much people are willing to push to do whatever they can to still drink and party with their friends. In that younger age group that you're saying is coming up with a lot of the cases. Because even in my own friends or people in closer friend groups that I know, they're pushing to have parties, or they'll just do whatever they can to stay out later and all this shit. And I'm
I think there's become a real COVID fatigue. People are just tired of it.
Yeah.
And I think, again, 99% of people get it and understand. And even those young people who are, partying, I think if you took them aside and said, hey, Bob, do you want to kill my grandma?
Yeah.
Bob's going to say, of course not. I go, well, Bob, but what you're doing through your actions is putting my grandma at risk. I think Bob would feel about that. In fact, I think even, a lot of them, when they're doing activities that they know they shouldn't be doing, they have some sense of, I know I shouldn't be doing this. That lasts until 2 drinks.
Yeah, it doesn't last long.
I mean, alcohol and, it's like the catalyst for spreading the virus. Your inhibitions go down, you're in close proximity, you start yelling at each other and laughing, and that's how you end up spreading the virus. So, but yeah, I mean, I think people basically are pretty, are decent and understand this, but it does get pretty frustrating, and you get pretty sad sometimes when you see some of the situations, like just Halloween. How can anybody be so irresponsible? And there's 1,000 people packed together, downtown on Granville Street. So I don't know what the solution is. I don't think you can lock everybody up. So.
No. Yeah, it's kind of like the world has to move on.
I'm pretty sure, though, if the pandemic was affecting young people and they were the ones that were dying, they wouldn't be all partying together.
No, that's true.
Pretty sure. All the seniors would be all out partying and drinking.
Yeah. The old folks' homes would be crazy.
And all the young people are going, no, please don't do that. Yeah.
No, it would probably be the exact same reverse if that was the case.
Probably not.
Yeah, maybe not.
It does make you laugh a little.
So. Yeah. With the COVID stuff and the other, well, I guess like in general, do you see like an increase in mental health over the years of being a doctor, like becoming like a thing?
I think mental health issues have always been present. I think in my 30-year career, I think definitely it's more acceptable to talk about mental health. Sadly, I think there still is some stigma attached to it. I think less and less so. So is there more? I don't know if there's more, or maybe just people are more willing to talk about it. Some of my older patients, you talk to them about their family, and my mom, she took to her bed for a year. She had a nervous breakdown. She took to her bed for a year. Well, that's not a diagnosis. So probably her mom had just overwhelming severe depression and just couldn't function for a year. But, people didn't really talk about it. And, I'm encouraged. I mean, I think people are talking about it more and more. I think it's okay to admit that you have some mental health challenges. I'm the first to admit I don't like November. I normally try to escape for a week in November and go someplace sunny. I am so blessed to be able to do that, but I can't do that this year. So I can already sort of feel kind of like I'm less energetic. My motivation's not quite there. I'm just kind of a little sad, and that's part of who I am. By me talking about it, that's a good thing. Somebody else say, hey, you know what, I got that too, or And like I said before, I think men have traditionally been really poor about talking about mental health, and I do think that's changing. I think credit to people like you. You're sharing your story. You're just unabashedly saying, hey, this is my journey. This is my story, and people learn from that, and people get brave and they're willing to talk. So good on you.
Well, thanks. Yeah, I don't know. I don't know what else I want to ask you.
Well, that's fair enough.
I was kind of curious about like the medications and the long-term stuff.
Yeah.
What is your view around that stuff? With some like initially what you said about using them.
By the fact that you say that stuff, where are you?
You know how much I like it.
It's garbage you try to give me.
Well, I feel like I was definitely, not going to lie, like I was very against it.
Yeah.
And I think a lot of that was like PTSD from, I had done drugs and things before I was experienced that severe anxiety. And I would also feel that after I did drugs, but at the time I didn't know what it was. I just think it was a hangover. So in my mind, I was calling it a hangover. But once I became aware of what it was through coming to see you and other people, then I linked the then I linked the drugs to the anxiety, and like how it would make me like I didn't like how I would feel like not in control of like my body and stuff. So that scared me to take anything else that was a pill. It didn't really matter what it was. Even if I went in, like, I would freak out if I was going to take a vitamin C, because I would be like, shit, like, I don't know, maybe it's not vitamin C. What if it fucks me up? So I was very scared to take anything. It wasn't really just...
How about Flintstones? Flintstone vitamins?
Even those.
Even Flintstones.
Anything. I didn't want to put anything like in my mouth. Well, food, and even food scared me sometimes. But either way, I was definitely very against it. I didn't want to take it. And then even after, like, I'd been through the natural approach, sort of like dealing with a natural path and doing some diet change and all the lifestyle stuff you talked about, I would, like, anytime someone told me that they were going to take medication or do it, I was like, fuck, man, that's just going to kill you. You shouldn't do it. But in reality, I'd actually never experienced it for myself. And I think that's very hard, because I believe in trying stuff too. Like, how do you know? Like, in reality, I shouldn't ever say anything about medication because I've never even tried it. So how do I even know what it does? Especially in a sense to like my mental health.
Do you have a list of all those people so I can talk to them? All those ones that you said, don't do it.
No, I don't. I mean, well, I have friends who take it, or friends who've tried like different ones. Like, man, like I want to try it. I'm like, okay, like. And then I would kind of come back to what you said. I'm like, okay, I think if you're going to try it to level you out and allow you, because sometimes people are so messed up, they can't put a good lifestyle in place. Like, if you're that deep, you can't just get up out of bed and go for a run and make food.
Yeah.
You might be so dark or down, you want to use them.
If someone's severely depressed, they really don't have the motivation to do anything.
Mm-hmm.
Oh yeah, so the whole topic of medication is huge.
Yeah, it's a lot.
So let's explore it a little. So like just the starting point is that medication is not the be all end all. So you have the whole 3 areas that I mentioned, and they're all equally important. So lifestyle, super important, exercise, all those things, counseling, seeing a good therapist, really important as well.
Mm-hmm.
The medications that we use to help, particularly depression and anxiety, there's the tranquilizers, like I talked to you about, the Ativan, the lorazepams, etc. The benzodiazepine sort of class of medications.
Mm-hmm.
They have an addictive potential. They're not meant to be the mainstay of your treatment. Like a rescue treatment, overwhelming anxiety, panic attacks, they have a role.
Mm-hmm.
The other medications have no addictive potential. And really what they do is they help elevate the neurotransmitters in your brain. If you take a depressed or anxious individual and you actually do a functional scan of their brain chemicals are functioning at lower levels than they were prior.
Medication has a role. It's not the end all be all. It shouldn't just be, I'm just going to take medication.
Mm-hmm.
I guess the only thing I would say about that, for those people I was talking about who really have a genetic biologic depression,
Mm-hmm.
Sometimes medication's the only thing that really makes a difference to their lives.
Mm-hmm.
So, I mean, their lifestyle's good. They don't have any issues. They just, sadly suffer, genetically runs in their family from mood disorders.
Mm-hmm.
But going back, the 3 areas, number 1, lifestyle is super important. Exercise, taking good care of yourself. Number 2, counseling, therapy, dealing with the issues in your life. And then number 3 is medication.
Mm-hmm.
And there's really 2 sort of avenues in medication. So the first is tranquilizers like Ativan, like we talked about before, which have an addictive potential. So they're not meant to be used as the mainstay of your treatment. They're sort of rescue medications. If you think of your little blue inhaler, if you have asthma, as your rescue medication, your Ativan's kind of your rescue medication, or something to use as you're trying to get, established on a medication. So the medications that we use for depression and anxiety, they work on their neurotransmitters in your brain. So they have done some studies. If you take somebody who's not depressed and measure their brain chemicals to compare to when they are depressed, there's a significant change.
Mm-hmm.
So the medications help upregulate the receptors and then help gradually increase the neurotransmitter levels in your brain. So it's not like you take a pill and you feel better. You have to get established on the medication, get through any potential side effects, and allow the medication to work.
Mm-hmm.
And that can often take a long time. It can take every time you make an adjustment to a dose, it might take 4 weeks, 6 weeks for your body to sort of adjust.
Mm-hmm.
So it's a gradual process. The beauty of them is they're not addicting,
Mm-hmm.
and they work well. So for, people who don't like the idea of medication, it's always worth exploring why.
Yeah.
They often have an experience like, crazy Aunt M took medication her whole life and she was just bat wing nuts as when she started.
Yeah.
Or like your experience that you shared, like you had some adverse reactions after using drugs that sort of that was a trigger for you why you didn't want to take prescription medications. I have seen so many people's lives improved, quote, saved by taking medication.
Mm-hmm.
So I can share my experience.
Mm-hmm.
Are there people who try medication and they don't like it? It's not for them. It doesn't really seem to be effective. Yes, for sure. I think if we can take the stigma away from thinking about using medication to help a mood disorder, help your mental health, I think that would be really beneficial. So if somebody comes in to see me and I diagnose them, say with diabetes, Shelby, and I say, hey, your sugars are really high. You need to take this medication to lower your blood sugars. In general, that's not a hard sell.
Mm-hmm.
People go, okay, well, I get that. My blood sugars are high. If I leave them high, something bad could happen to me and I might die.
Mm-hmm.
Or if somebody says, hey, your blood pressure's through the roof. If we don't bring your blood pressure down, you're going to have a stroke or a heart attack and die. People are usually, okay, I need to do that.
Mm-hmm.
But if, you say to somebody, you have really bad depression, I'd argue it's a good depression. Anyways, you have quite severe depression and you need to take this medication, or I suggest you take this medication to try to treat your mood disorder. Often that's a harder sell.
Mm-hmm.
And I think that all ties really into the stigma of mental health. So I don't think you should think of medication as your first option, but it should always be an option.
Mm-hmm.
One thing I like, an analogy is you're doing everything right, like you're exercising, you're taking care of yourself, your diet's good, you're staying away from alcohol and drugs, and you're seeing a therapist, good therapist, you have good sessions, but you're still just really sad. The equivalent is your car's stuck in the mud and you just keep hitting the gas and the wheels are just keep going around, but you're not getting anywhere.
Mm-hmm.
It's time to do something else.
Mm-hmm.
And, the thing I always tell people about medication, it's not a one-way street.
Mm-hmm.
Like, it's not like, if you don't take this pill, I'm going to hire people to come to your house and hold you down and inject you with, medication.
Yeah,
right?
yeah.
I mean, you have free will here, but often I say, well, what's the downside of trying? Well, you might get side effects and you might stop then.
Mm-hmm.
But it has the huge potential for, make an improvement in your symptoms.
Mm-hmm.
I have patients that life on medication is good and life off medication is terrible.
Mm-hmm.
They function extremely well. They're happy as any of us are happy.
Mm-hmm.
And, on medication, and if they stop, everything deteriorates. And if you sort of extrapolate that to people who have, other mental illnesses like schizophrenia, a schizophrenic who is psychotic and having delusions, that they have superpowers or they're God or, that person needs medication.
Mm-hmm.
You can't lifestyle or therapeutize that person out of psychosis.
Mm-hmm.
Bipolar people who are manic, that means that flight of ideas, they don't sleep, they have tons of energy. They buy a fishing boat, that they're going to go fishing in the Atlantic and make millions of dollars, and they don't even know how to run a boat.
Mm-hmm.
They drive dangerously. They get involved in sexual behaviors. They spend money they don't have. I mean, those people's lives, like they're gonna ruin their life if they don't take medication to get them out of that manic phase.
Mm-hmm.
So I think everything has a role, but definitely medication shouldn't just be the role. And I think
Yeah.
as physicians, we're a little bit guilty in that you come see me, I've got so many, minutes to see you, and I can't spend an hour talking about lifestyle or whatever, but
Yeah.
I can give you a prescription.
Mhm.
And I mean, I really try not to be that person. And I think the majority of physicians are the same.
Mm-hmm.
But I mean, was it back in the 60s? Everybody took Valium.
Mm-hmm.
There's an antipsychotic drug called stelazine, another one chlorpromazine. These were like came out in like the 60s, and there's actually ads, suggesting if you're a tired housewife, you should take chlorpromazine or stelazine. So things change. Right?
Did they still have ads like that now?
No.
Yeah.
But this was back, some of the old magazines. Like I've seen some of the ads, and it's like, whoa.
Because there's like they can't advertise like that anymore, like direct drugs to people.
There's very strict regulation. All the drug ads you see on TV are American. Like you see grandma frolicking with the kids, and they say, grandma's arthritis is under control. Her life's so much better since she's been taking this medication. And then they spend the next 45 seconds of the commercial telling you how it'll kill you.
Mm-hmm.
Get this, get that, don't do this, don't do this, do it.
Yeah.
I mean, those are made for the lawyers, not for. Yeah, that's American.
We don't have them in Canada anymore.
No, we don't really have a lot of. There's definitely strict drug regulations or regulations on medications in Canada. Just like with alcohol, I don't think you're allowed to show anybody in a Canadian beer commercial drinking beer.
Oh, they can just like hold it.
Yeah, you should double check that, because I could just be entirely making that up, like most stuff I say.
I'm gonna look that up.
But I think there's some regulation why you can't actually be drinking alcohol. You could hold the alcohol and like happy about it, but you can't drink it.
Oh, that's cool. No, I'm gonna look that up because I'm doing that 30-day sober challenge thing right now. So I'll use that as one of the emails.
Into it, and then let me know if I'm full of it when you find out. But I remember hearing that someplace. So
Yeah, because they like to bring the drug. And like, I guess this is another question. Like for you, like, is it your practice?
Meaning, like, did I steal it from somebody?
No. Like when I come to your doctor's office, is it your doctor's office, or do you work there? Like,
so you're wondering about my business arrangement. So we're not a partnership. So there's 6 of us there.
Okay.
We're what they're called. It's called a proprietorship, or we're associates. Not really associates, but we're all individuals. So we're not a group entity. So legally, we're all different. So we cost share.
Okay, cool.
So we have an office, and
so it's essentially all your practices. It's just your own office.
And then we have a monthly expense that we split. So each of us pays 1/6 of us. And then, we're all involved in the business decisions of our practice. So we have a monthly meeting where we all get together and we talk about various issues. So,
and like for the drugs and things that are available, do you have access to like say there's like obviously a list of drugs. Where does that list come from? Like can you just pick anything to give someone and they go to a pharmacy, or like, are you only allowed to sell certain ones, or is there like
I can get you whatever you want. What do you want? What are you asking for?
Yeah,
this is how doctors get in trouble.
Yeah.
What would you like? No, I can prescribe anything. So I guess
maybe that's another thing in the States. Like basically, when they show like people coming in to like doctors or hospital and trying to sell them to sell their drug, you don't have that. You just get to choose from any drug.
Correct.
So this is different.
The United States and Canada are very different when it comes to medicine. So America is financially driven. So hospitals are for profit. Their bills are huge. The medications down there are more expensive than they are in Canada. They're still expensive here, but so there is a for-profit system. In Canada, it's almost the reverse. So in general, in Canada, the thrust is go as cheap as you can. So, there's groups that will do studies to show that, this medication that's cheaper than the other medication is just as good. And then encourage physicians to prescribe that. We have, campaigns to prescribe less antibiotics. We have campaigns to, use less medication, which I think is a good thing.
Well, that's cool.
The downside of that system is if there's a really good medication that's new, it's almost never covered. So we have pharmacare. People get different coverage depending on their finances and their means. Pharmacare, quite conservative, doesn't in general cover new medications, or if there's a cheaper alternative, they'll cover that one. So I think in your question was, how do I decide which medication to use?
More so just like how, no, like that. I was more so asking what you answered. Like how, like what do you have access to, and how do you get the drugs you get to choose from, really? Which I think that's like really, that's different than I thought, because when you watch the movies or you hear about, I mean, I think that's a good piece of information for people, because even me, I had no clue how it worked, and I just assumed it was the same as the States. Like they sell you shit, you make money from it. Whereas now, I think that's useful for like the listeners here, because they go like, oh shit, like they're actually trying to do less of that. And it's like the complete opposite, because most people think that. Like when I talk to people, like, well, they're just making money. They're just making money. Whereas like,
I'm gonna nip that in the bud right now. I do not get paid to write prescriptions. Whether you leave my office with or without a prescription, it does not change a thing. So my goal in general is people leave my office without a prescription. The least amount of medication people use, the best it is.
Because the medication doesn't even go through you. No. Like you write that piece of paper, but then it goes from like that. It's like direct to consumer to the person. You're not in it.
Pharmacies would really like you to all be on medication.
Yeah.
That's how they make them. I mean, nothing against pharmacists.
Yeah, I mean, they have to make it.
And a good pharmacist is worth its weight in gold. I remember one woman coming in and saying to me, she had, I don't know, I think she had like a bronchitis, and I was giving her an antibiotic, and I think it was like, the one I was giving her was a pill twice a day for 10 days. And she said, you guys get paid for prescriptions, don't you? And I said, ma'am, I don't know anything about that, but here's your 20 prescriptions for one pill each. Yeah, no, we don't get paid to write prescriptions. I don't know where that came from. The other one I hear is, doctors know the cure for cancer. You ever heard?
Yeah. Well,
like, doctors know the cure for cancer. So I'm like, okay, so if you think I know the cure for cancer and I'm not telling people, that would make me like the most despicable human ever. Why would you come see me?
Yeah.
Are you hoping you get on my good side and I tell you the secret?
Yeah.
And then what about the doctors that die of cancer? Is it like, Bob, I'm sorry, but you have to die of cancer. You have to have colon cancer. We got to keep the secret, Bob. I'm sorry.
You got to take one for the team.
You got to take one for the team. We're sorry, man. Your number came up. Like I don't know. People get strange ideas. I guess just look in the United States and what's going on with their political climate about strange ideas. So.
Yeah, I mean, I think a lot of it is influenced from there, and I think especially a lot of it just comes from, like for me, it comes from movies and stuff. From what's the movie with where Buddy has AIDS? It's a true story. Matthew McConaughey.
Oh yeah, something to do with cowboy. I can't remember the name.
Yeah, I forget, but he's like a cowboy in it. And when he goes into the hospitals in that movie and the doctor's offices, the drug companies are like pitching to the doctors and telling them like, hey, like if you sell our drug, or if you sell our drug, we're going to give you all these perks and all these things. And it gives you like it gives you behind the scenes view, but I mean, it doesn't necessarily mean that's true or how it works here. So I think everything that I've seen is mainly movies and things that are actually produced in the U.S. So like it's about the U.S. system and not necessarily here.
Although, like, just shouldn't let us completely off the hook, because there are pharmaceutical reps.
Okay.
So they come. So through the years, like 20 years ago, pharmaceutical reps would take you to play golf.
Yeah.
Or, they'd have dinners where they'd wine and dine you. And the regulations have become much more strict because, people say that potentially that's a conflict of interest. If some drug rep is giving me free stuff, I don't see the problem. If I get lots of free stuff, clearly it's a conflict of interest.
Yeah.
So it's very, very regulated now. So they don't, they can't even give you a pen.
But what are they trying to sell you on anyways?
So they would have, because within a class of medications, there might be 5 let's take depression.
Mm-hmm.
You know, just to say there's 5 really good SSRIs, which are, you know, serotonin reuptake inhibitors. They're a class of medications that work well for anxiety and depression. Say there's 5 of them and they're all pretty equivalent. The pharmaceutical rep wants you to choose theirs.
Mm-hmm.
So they're going to come in and give you a presentation of why theirs is better.
Mm-hmm.
But I don't think you can really use their information at face value, because they're not going to tell you the truth that they don't want you to hear.
Mm-hmm.
I mean, they'll tell you the truth. They're not allowed to lie to you about about studies of why this did this or that did that. But they're not going to tell you, yeah, but you know, drug C, our competitor, actually did this study where they showed they were better in this area.
Mm-hmm.
They're not going to. Well, they wouldn't be a very good rep if they told you that.
Yeah,
right.
At least to their company.
So you have to take that with a grain of salt. So in general, I don't see drug reps. You know, like in general, I just don't.
So because they're not, like, that still doesn't give you a commission on their sale, though.
Nope.
They're just asking you to promote it so they get the sale through the pharmacies.
Yeah. So a pharmaceutical rep, if their sales for their drug increase in their area, I think they're going to get rewarded financially for that.
Yeah, they will. Yeah.
Right. So no, in their defense, again, what if their drug is the best?
Mm-hmm.
Right. And they're just trying to spread the word that, hey, listen, our drug is the best. Maybe it wasn't the first on the market, but it's the best. So, you know, you should consider it.
Mm-hmm.
And, you know, I think what most physicians do is you're not going to use all 5.
Yeah.
So you're going to decide, hopefully based a little bit on science and experience, which 1 or 2 you're most comfortable with, and have, like, you know, those are your go-tos. So, so if someone fits the criteria of depression that you think needs treatment, your first choice is usually this. If this one doesn't work out, your second choice is usually this, and you have reasons why you do that. And that would be the same for diabetes. It'd be the same for, you know, heart failure, high blood pressure. You try to, you know, you can't get familiar with every drug.
No.
Right? You kind of want to choose and know a fair bit about the ones that you're prescribing. So you can, you know, give patients informed consent as well.
Yeah. And like for some of those drugs too, like say the ones that you've chosen for like mental health, have they been around for a long time, or is there like constantly a lot of them coming out?
Yeah. So there's always new and better. New and better isn't always new and better.
Yeah.
I mean, despite how it's kind of like, you know, any consumer good, you know, the next one, the new one, it's better, it's newer, it's faster or whatever.
Yeah.
So I tend not to jump on bandwagons. Like if there's a new medication out there and they're saying all these wonderful things about it, I'll often say, well, why don't we just wait, you know,
a little bit
and see what the experience is.
And do you see them like drop off? Like say someone launches a new medication and they come and sell you on it. Does it stay on the market forever, or they just go, okay, like no one's really using this, they must have to not sell it? Or is it really large companies constantly trying to create new things?
Yes, there's always, this is a whole fascinating area. So it used to be you created the drug, you get the patent, you keep the patent of that drug, you're the only one that can make it and sell it.
Okay.
And then they decided that, well, that's not okay, because then you can just artificially keep the price of your medication high. So they have limits on patents. But what's happened now is that means any new drug that comes out that's really good, the company that did all the R&D has to get all their profit out of it within the first number of years, because then the patent expires and then the generic drug companies can make it.
Oh, so you can't hold that patent forever.
No. So you know, like Viagra brand, like you heard the commercials, there's now a name brand Viagra, right? So they had to get all their money out of it when they first released it, right? And now the generic can make it, so, you know, they can't get their money out. So actually not artificially, it makes usually often newer medications are more expensive initially because the drug company's trying to get all their money out of it before their patent expires. So in answer to your previous question, medications that are good, that work well, stick around.
Okay.
So if there's a really good medication for blood pressure and it works and it's safe and you don't have side effects, it sticks. Eventually it gets cheaper because the generic companies start making it, you know. If there's a medication for blood pressure that, you know, had some significant side effects, didn't work that well, it'll drop off. They'll stop making it. But you're probably right, you know, like in probably some degree of a cycling, and a new medication comes up, everybody says all these wonderful things about it. The sales go up and the use goes up. and then probably it filters down to the level that it should be.
Yeah.
And then if it's something else comes along that's better, then that's going to probably drop off the back end.
Mm-hmm.
You know, like we don't put leeches on anybody anymore.
Mm-hmm.
You know,
Yeah.
because people, you know, we don't bleed people anymore. You know? And you know, 50 years from now, I'd like to think that's not going to happen, but there's going to be a bunch of docs sitting around going, "Can you believe that 50 years ago, this is what they used for this problem?"
Mm-hmm.
So, because things evolve, right?
Yeah,
So,
can always be the case.
you know, and you even look at the like mental health, the things that people used to do to treat mental health, you know, insulin-induced seizures, you know, lobotomies, you know, all sorts of like shockwave therapy without any sedation,
Mm-hmm.
you know, locking people up in asylums. I mean, you know, we're evolving,
Yeah.
right?
Yeah, I even talked to my grandpa about it because I was curious. I was like, man, like, was this always a thing? Like, when you were 20 or like younger, what did you call it, or what was it like back then? And even doctors, he was like, man, like now there's like neurosurgeon doctors, psychiatrists, like all these different people. He's like, back when I was like 15, 20, like you go to the doctor, they do everything. He's even dentist. He's like, doctor pulls your teeth, doctor does your broken leg. Like there was just a doctor. There wasn't everything else. And he said that basically, like if they thought you were mentally ill, they just sent you to like a mental illness, like a insane asylum, and that was it. Like that's where you went.
Yeah.
That's all you
Goodbye,
get.
Bob. Have a good life. Yeah. It's pretty sad.
Mm-hmm.
A lot of sad stories. And I mean, definitely we've come a long ways from that, but I still think there's a long ways to go for mental illness. Even if you think about shockwave therapy, since I brought it up,
Yeah.
it actually has a role.
Mm-hmm.
So, you know, people say, what? Well, for whatever reason, having a seizure, it's like reset up, you're rebooting your computer.
Mm.
And it seems to really make a difference to people who have treatment resistant depression, you know, psychosis, that often actually ECT will actually make a huge difference to someone's life. I've had a few patients have it, and it's been a lifesaver for them.
Really?
And but the way they do it now is they give you a general anesthetic. They put you to sleep, and they actually give you medications that paralyze your muscles. So it's like when you have your gallbladder out, it's the same procedure, and then they induce a seizure in your brain. So
so it's not like having a crazy body seizure.
You don't thrash around, and you just the electrical activity of a seizure, which is that's essentially what it is. It's, you know, unrestrained electrical activity that spreads around your brain, happens with you just lying there peacefully sedated. So
and that's done through the medical system, like in a hospital.
Yes. Yeah.
Oh, that's cool. I never heard of that before.
Yeah, and again,
like
it's for really sick people.
Yeah.
You know, kind of like thinking about like if someone has a heart that's failing, you know, the ultimate thing is a heart transplant. I mean, that's for the really, really sick, right? So
yeah, it's kind of like maybe
you don't have a little chest pain, and I go, hey Shelby, you ever thought about a heart transplant?
Yeah. Although I would have maybe liked that back in the day.
Yeah.
Oh, that's awesome. Yeah. It's cool to hear about all the like actual kind of behind the scenes of like the drugs, how they're made, how like the office works and stuff. Because I think a lot for me was like actually based around that, where I'm kind of like, okay, I just kind of, maybe it was like, and maybe it wasn't even just the doctor, maybe I didn't believe in the system, or that's what other people are against too. It's like, it's not just the person you're seeing. For me, a lot, it's like what's going on behind, and like if you're believing that it's a money grab and this big scammy thing, it just doesn't make anything about it feel very good.
Yeah, and I think there's definitely people who view it antagonistically, like it's a system.
Yeah,
you know, like, which I don't know how to dispel that. I mean, it comes from somewhere for people, like whether, you know, their friends are talking to you about it, or whether there's some family issue that, you know, has led to that, or some preconceived idea. But I mean, the people in the medical system in general, I can tell you, are good people who are trying to help. I mean, does the medical system have some bad eggs? Sure. Doesn't every profession?
Yeah.
You know, I hope I'm not one of the bad eggs, but
no.
But yeah, so I mean, I know, like I can tell you the people I work with, you know, we're trying to do our best to try to help people. Sure, we all have our limitations, doesn't everybody? But
yeah.
Do I ever get grumpy? Sure. Do I ever say things to patients? I go, really, Dave? Couldn't you just have held that in? Sure, you were a little irritated. Did you really have to? Couldn't you just held that in for a little while longer? Yeah, sure. We all have bad moments, right? So,
yeah.
I just wish I'd had a better moment when you came to see me.
Well, I don't know. I mean, I think it's still good. Like at the end of the day, maybe it wasn't, the best case scenario then, but to me, it's like the best case scenario now.
Maybe it's the journey that you needed to go through.
Yeah, that's the thing. I just feel like everything happens for a reason. And like I used to hold stuff against people a lot where it's like, okay, they didn't do this or they did that. But again, it's just like, I don't know. That's just the way things happen and it happens. That's what am I going to do about it?
It's true.
I can sit there and, dwell or cry about it and whatever. But I think it's cooler to do this now and like get to reach out and, kind of uncover things that happen and learn about the things that I should have asked back then, right? Like if I would have asked these questions then, I would have probably tried different things and done other stuff as well. And so I think that's cool. And
well, I think it's like we talked about earlier, it's a learning process. It's a learning process for me. And I hopefully learn from my patients as well. Like hearing your experience, that's in there now. So, I could maybe use that moving forward with somebody else, maybe make a little bit more of a difference. So,
yeah, I think that's awesome. And like, I'm super stoked too that you came out and did this because I think for me, like I was definitely nervous to reach out to any doctors. And I was like, man, I don't really want to reach out to mine because that's like, that might be weird. I was like, but I don't know what they're going to be willing to talk about.
It is a little weird.
Yeah.
No, it's not. It's all good.
Yeah. And like for me, I don't know. I was just like, man, I don't know what will they talk about? Like I was even nervous that I thought you might not want to talk about drugs or say like kind of how the behind the scenes work and things like that, where like it's definitely what.
I don't know. Information, education, those are powerful things. They're never a negative thing.
Yeah. And it's like, it's nothing really to hide. It's just how it works.
We just bury our mistakes, right?
Yeah.
So that's what everybody says. Yeah.
Yeah.
We just hide them. Little door under the office. Yeah. I think, like I say, 99% of people are decent people just trying to, live and love and laugh and, take care of their families and, try to get along with each other. So, I mean, I think that's what's to remember. We're all in this ball of dirt together, hurtling through space. So let's try to support each other.
Yeah, that's awesome.
I even have that as a saying. So sometimes, if, your life can get really hectic and crazy, and you're just like frazzled. And I just say to myself, ball of dirt, because how much control do you really have? We're just on a ball of dirt hurtling through space. So that could end any minute.
Yeah.
Big giant just goes squish.
Yeah, it's crazy to think about sometimes where you're just like, I use the same thing. I read a book and they talked about like, if you're feeling like anything bad or like, same thing, frazzled, whatever, you're just stressed, like literally just go outside and stare at the sky and remember like, man, you're just on this chunk of earth, nothing flying through space. Like, what does it even matter?
And not to take anything against people who have a strong faith, right? So I mean, it's just we all have different perspectives, but even if from that basis, if you have a real strong faith and there's a different perspective, it's still you're still at the whim of somebody else, right?
Yeah.
So
yeah, exactly.
Yeah. Anyways,
awesome. Okay. Well, I think good to cut it there.
Okay.
Yeah, thanks for all the information and
problem.
sharing and coming out and being willing to do this. It's been awesome to be able to reconnect and talk about this stuff years later and hopefully stay in touch and do some more biking and other things. And
for sure.
Yeah.
This time, if you could slow down so I could keep up, I appreciate
I think
that.
that's the other way around.
No. Don't listen to him.
Yeah.
Anyways, thanks, Shelby. I really appreciate it. Thanks for having me.
Yeah. Thanks for coming out. It was good.
No problem.